then you guys.
All right, so we're going live, guys. We are live.
We're live already?
Yeah.
Oh my gosh, we are live. Hey guys, welcome to Medicine Deconstructed Live. I'm going to try to link this post or this live to our Instagram channel right now. So copy this link here, and I'll share it here.
I'll even send you the icon. You want that?
It's already done. So I hope everybody's doing well today on Friday afternoon. I think it's important for all of us to know that coronavirus is not going anywhere. SARS-CoV-2 is here to stay. It's going to be here for a while. There have been lots of things that have been talked about. And as far as treatments, we have FDA approval for remdesivir. More studies are being published right now that show that tocilizumab, an IL-6 inhibitor, doesn't seem to benefit patients as much. Maybe it does, maybe it doesn't. It doesn't look like it. Convalescent plasma also may not be of benefit, at least at the time in which we're giving it now. As you guys have always, or as I have always stated, I do think that timing is extremely important. And it's very difficult for medicine in general, for us in general, when we're studying these things, to give these medicines to patients who aren't very sick. And so what happens is we tend to give medications we think are going to have an effect on someone's life. We tend to give these medications when they're severely ill, or in between being ill and severely ill, so that you have this impact so we can test our efficacy. Again, I've always felt that that's one of the issues that we have with medicine, but it's the way right now. Until someone can come up with something new, it's the way it is. That's how evidence works. That's how randomized controlled trials work. And if you want to have the biggest bang, somebody's got to be sick and they've got to get better. Now, today we've recorded several YouTube episodes. We've talked about complement and COVID. We've talked about pregnancy, infants, and COVID. We've talked about how to trick your immune system into fighting cancer. Again, I'm always talking about immunology. And hopefully those episodes will turn out. Lately, in terms of immunology, you've heard this term herd immunity, right? What is herd immunity and what does that even mean? So herd immunity actually means that a certain number of people have had a certain illness and have immunity to this certain illness, that it is very unlikely for you to get that illness as a result of it. So in other words, if you've got 20 people in a room and 17 people have had this type of illness and have developed an immunity to it, that means that the next person that walks into the room, they're unlikely to get this illness because the other 17 can't really pass it on and probably aren't really contagious because they're already immune to it. So the concept of herd immunity, it's a good concept to want to achieve. Unfortunately for SARS-CoV-2, with the R0 being anywhere from 2 to 3, and R0 means the amount of people that you're infecting when you have the infection, to develop or to achieve herd immunity, we would need like 70% of our population in the United States to have the illness, right? And so that is either they have the illness and everybody's battled through it and developed immunity that lives, or we become immunized or we develop a vaccine, right? That's another way of achieving herd immunity. And I think people need to understand that. I understand everyone's worry about vaccinations and everyone's worry about things being developed quickly. And I put quickly in quotation marks because we have to understand about the development of vaccines is that people are developing vaccines all the time. Depending on the prevalence of an illness is going to increase that priority. So with SARS-CoV-2 and its prevalence and incidence just going up, laws were passed. Operation Warp Speed was passed, which allowed several different protocols to be taken simultaneously, which allowed us to have such speed, so to speak, with developing these vaccinations. So the way a vaccine works essentially is when you have a vaccine, you're getting a piece of the virus or the bacteria. You're injecting it in your body so that your immune system recognizes it, right? Your immune system is going to develop antibodies to it. It's going to develop other types of cells to recognize it and kill it. So that way it becomes that much faster when you actually encounter the illness. I mean, that's how the flu shot works, right? Is you inject it, your immune system recognizes it and creates a defense system against it. And not only does it create a defense system against it, but it understands how to build the army against that pathogen. That's how vaccines work. And I understand people being worried. And again, when you look at all these clinical trials, and you've had some adverse events, right? One person in England ended up having what we call a myelitis, essentially. Their spinal cord became a little bit inflamed, a transverse myelitis. Out of 18,000, it was one person, and the vaccine trial was put on hold. One person out of 18,000. The whole vaccine trial was put on hold. Again, I know this is going to be, I know it's difficult to understand, but I think about it like this. It's almost like when you're driving a car and you get into an accident and then you just don't allow anybody else to drive. So, nope, you can't drive because we had this one accident. That's what I equate this to. Would you ever do that? I mean, there's accidents every day. We drive every day. There's always risks involved with the things that we do on a daily basis. There's risks involved with the manipulation of the immune system. I understand that. We recognize that. And we take those kind of risks. So one person out of 18,000, yeah, I'm concerned. I hope that person is doing well now. And from what I'm hearing, they are. I understand it, but I get that. I get that aspect of it. As a physician, I train medical students. I've got a medical student with me now. And he just started Tuesday. And the school that he goes to is a pretty good school. But he doesn't know that much about the lung. And it's my job to teach him pulmonology. I'll teach him a little bit of critical care, but mostly he'll learn pulmonology and some internal medicine from me. And so what he's going to do right now is he is going to ask questions that he wants to know the answer to. I'm going to teach him. I'm going to show you guys what I do to teach medical students. So he's going to start. He's going to ask a question. I'll repeat it. And I'm going to teach you some of the things that I teach him on a daily basis. So Brian.
Hey, Dr. Rutland. How's it going?
Good. He says, hey, how's it going? What's your first question?
So my first question is, what is the basic unit of the lung?
So he says, what's the basic unit of function of the lung? Now, I've talked about this before. The lung is essentially designed as a lot of pipes that lead to a bunch of balloons stacked on top of one another. These balloons will collect in a unit that we call the secondary pulmonary lobule. Within a secondary pulmonary lobule, it's outlined by what's called interlobular septa, which is where the lymph tissue is, where the white blood cells travel, along with other connective tissue. And in the center of the secondary pulmonary lobule is the bronchiole, the airway, and the pulmonary artery. Pulmonary artery is delivering deoxygenated blood to the alveoli, so that the alveoli can then receive that blood from the pulmonary artery, which ends up turning into a capillary, just a big long pipe. And then when we take that big breath of air in, the air travels to the alveoli, and the 21 out of 100 molecules that are oxygen, they will diffuse across that capillary membrane to get on our bloodstream. Now, when you think about the lung, understanding the basic unit of function, the secondary pulmonary lobule, is important because all the diseases are related to this. So it's almost like what you want to know when you're looking at the secondary pulmonary lobule is, where is the disease that I'm talking about taking place? So let's look at asthma, for instance. Asthma is an autoimmune disease that affects the pipe that carries air to the lung. So the bronchial is what's going to be diseased. You're going to see inflammation there. Interstitial lung disease. Well, the interstitium of the lung is going to be inflamed. Interstitium is the connective tissue, the interlobular septa. That's connective tissue. Interstitium travels around the bronchial and around the pulmonary artery. That's interstitial lung disease. Inflammation there. Also inflammation in the secondary pulmonary lobule, as that's considered interstitium as well. So every disease that, as it pertains to the lung, either affects it in the bronchial, in the airway, carrying air to the lung, the conducting airway, the alveoli, right, which is where gas exchange takes place, or in the pulmonary artery or capillary membrane. Next question, Brian.
We have one a couple one listener question and some listeners lined up. Do you want to ask a listener question?
Sure. What do you think is the best hope for a vaccine of all of these trials, or all of the trials?
So there are several different trials going on simultaneously, right? And they're all in phase 3. Now, I've talked about this in one of the episodes on my YouTube channel on the coronavirus vaccine episode. There's an adenovirus vector, which means you're taking a piece of DNA of coronavirus, putting it in adenovirus, and you're allowing the adenovirus to transfect or infect our own cells, which exposes the immune system to coronavirus or a piece of it and allows it to generate a response. There's an mRNA vaccine, and then there's these inactivated vaccines or weakened vaccines, which means you're taking actually live virus and not allowing it to be virulent anymore, meaning not allowing it to infect us anymore, and you're exposing the immune system. So I think for me, the vaccine that I see getting approved probably first is one of those adenovirus vectors. I bet gets approved first. But I think that the best hope is for one of these inactivated vaccines to show some efficacy, as it has so far, and to make certain that it's safe, and that'll be the most effective. Now, in my mind, I'm guessing that a vaccine will be here around, at least for the general public, probably around next summer, maybe early fall next year, 2021. But I think for healthcare providers, it might be available as early as spring. And then we'll see.
Yeah, ask another question. Oh, and also just let the listeners know that they want to know if they can ask questions. So let them know.
Yeah, please, listeners, ask questions. If you guys have questions, that's why I'm here. I should be here for another 10 or 15 minutes. You guys ask your question.
All right, go ahead.
Brian?
So what does it mean? So sometimes when you're reading about CTs or X-rays, you see this finding called ground glass opacities, and I'm doing some other reading too, and it says like, oh, there could be cancer or something. So what exactly is a ground glass opacity, and should you be concerned about that?
So his question is, what exactly is a ground glass opacity? Now, we've talked about this in the CT episode. Now, what a ground glass opacity actually is, when you're looking at a CAT scan, and it's a CAT scan finding, one of my pet peeves is when people say ground glass opacity looking at a chest x-ray. It's not a chest x-ray finding. You can say soft tissue abnormality on chest x-ray, but I wouldn't say ground glass opacity. It's a CT finding. And the reason it's a CT finding is because its definition is an infiltrate in which you can still see the underlying architecture of the lung. In other words, you're still going to see the interlobular septa. You're still going to see the pulmonary artery. You're still going to see the bronchial. All right, that's a ground glass opacity. Now, when you look at CAT scans, the lungs are supposed to be black. You have little white dots in there, which can represent pulmonary arteries and maybe some interlobular septa, but mostly it's black. So ground glass opacity is this gray opacification on a CT scan. Now, when you look at the differential of a ground glass opacity, that becomes a little bit more complicated. Since we know that a ground glass opacity is essentially a gray type of color on a CAT scan, the differential is long, and it depends on the patient's history. So an example for me would be, patient comes to me, says, I've been coughing and I've had a fever, and he's got ground glass opacity on his chest CT. I would say that's probably a pneumonia. If a patient has a history of a malignancy and they've got cancer in lymph nodes and I see a new ground glass opacity, that might be a malignancy. If a patient has a history of congestive heart failure and because of their poor flow from their heart, they get this backup of flow and they've got this overall grayness on their CAT scan, it could be congestive heart failure, and that ground glass opacity could represent pulmonary edema.
All right, so the next question we have is from Karen Debuggy. What are your pet peeves for a nurse to do? I'm a new nurse and would like to improve. It's very political here. So,
Karen, so Karen asks, what are your pet peeves for a new nurse? Listen, we all understand that new nurses, just like new doctors, just like new parents, just like new anything, are anxious and nervous. From a nursing perspective, at least from a physician's point of view, my pet peeves, and I don't know if I have any real pet peeves with new nurses, but my pet peeves would be not understanding why the patient that you're taking care of is in the hospital, because you never know what's going to happen. So if a patient codes or a patient gets really sick and we arrive at the bedside, we're going to ask the bedside nurse, if we don't know the patient, why is the patient here? Being able to tell us why in 2 to 5 sentences helps our mind generate a differential diagnosis for what happened. An example would be when you guys are getting a report, you're going through your systems and you're saying, I gave him Tylenol, I gave him ceftriaxone, I gave him heparin for DVT prophylaxis. That's great. And if I come to the bedside and somebody is ill and you give me that list, I'm glad you know his medication list, but I still don't know why he's getting ceftriaxone. So a good report, at least for me, if somebody's ill would be, yeah, this is a 57-year-old guy with a history of cirrhosis who came in 2 days ago with cellulitis. He's been a little bit more somnolent and he's had a little bit more confusion over the last couple of days. And then today he just stopped responding. That tells me a lot more than he's getting ceftriaxone, he's getting DVT prophylaxis. So you have a story for me. So on one end, I'm still kind of wanting more. On another end, I'm thinking, oh, this guy's probably not talking because he's got severe hepatic encephalopathy and he probably hasn't pooped in a while, and I got to get rid of this poop. In other words, hepatic encephalopathy is a disease that happens as a result of the liver not functioning very well. Your brain gets foggy when your liver doesn't function very well, and when you have cirrhosis, which is scarring of the liver, so your liver doesn't work very well. And when that happens, people can become confused, somnolent, and just not respond. And so that's on that differential. But again, my biggest pet peeve is just not knowing why that patient is in the hospital. I think it's very important. I understand your report. I understand giving the meds, and I understand that the job is difficult. But at least for me, that would be the biggest thing.
All right, so we'll ask another. We're getting a little line here. We'll ask one more. Okay, so I have a woman, Rachel. She says, it's kind of a long question, but she says, she's living in a multi-generational household with her husband, herself, and her daughters. And she took over care of her mother 5 years ago. And she has 12 spinal cord surgeries and severe lung damage from smoking. She also gets pneumonia quite often. Let's see, no one wants to social distance from her or wear masks. We've been staying home and away from everyone. Should we continue to do what we are doing? It's been hard, but I can't imagine giving anything to my mom with her health issues. So
yeah. So it's what you're asking is, so the question is, my mom has severe lung disease, emphysema, probably, which is dead lung, secondary to smoking. And she's had 12 different spinal surgeries. I don't know the history of what's going on in the spine. It doesn't sound like she's on any medicine that suppresses her immune response. You're asking me a risk question. Is it risky allowing people to come in and out of the house for my mom? The answer is yes, but it's yes either way. With or without coronavirus, the answer is still yes. Your mom has emphysema. Emphysema is dead lung. Dead lung means that she doesn't have the reserve if she were to develop a pneumonia. So am I seeing a lot of patients with emphysema in the hospital with SARS-CoV-2 or COVID-19, I'm actually not seeing a whole bunch of people with emphysema. I'm not. But does it mean that she doesn't have a risk? Not necessarily. If she were to develop a pneumonia secondary to SARS-CoV-2 and COVID-19, she would be really sick because she doesn't have that reserve. As far as people not wearing masks, again, that's a respect thing. You're asking your family and friends to respect your rule, which is, would you just mind wearing a mask around my mom? I don't think that's unreasonable. If they don't want to wear a mask around you or you feel comfortable and safe, that's all you. I get that. But for your mom, it's a respect thing. You're asking them to respect your wishes and wearing a mask around your mom. I don't see an issue with that. I just don't.
Do you have any advice for her? She says she lives in Idaho and cases are on a crazy rise. And
They are.
No one wants to social distance or wear masks. Everybody's, they're probably like in the zone of.
Well, there's 38 states in which the incidents are going up. So she's asking like advice on how to get people to wear masks. I go through the same thing. I have my mask. I always have my mask. I always have it on when I'm within 6 feet of someone. But what I would say to that is you have to just tell them, listen, this case count is going up. Just respect my space. My space. If you have a friend, generally they're going to respect your space and respect you. That's all you're asking for is a little bit of respect. There's nothing there that is insulting or damaging. I'm not going to lie to you. I have lost some friendships because of that, right? Because people refuse to wear a mask. I get it. I understand. But again, just ask them to respect you in your space. I wear a mask because I'm the guy that sees these people every day. And that's what I tell my friends. Like, I see the guy every day. Like, I see coronavirus every day. I don't want to give it to you.
Right. Maybe just tell everyone your mom has coronavirus.
There you go. Right.
We all have coronavirus over here. You might want to wear a mask.
Exactly. Brian?
Is smoking marijuana going to damage your lungs as much as vaping or cigarettes?
That's a great question. So he asked, does smoking weed damage your lungs as much as vaping or smoking cigarettes? Here's the thing about smoking anything. Smoking anything ends up damaging some of the cilia in your airway. Your cilia are responsible for bringing the mucus up and getting rid of pathogens and just swiping them up so you can spit them out of your mouth or whatever. When you smoke anything, vaping, cigarettes, marijuana, it allows pathogens like Streptococcus pneumonia, which is a bacteria, to adhere to your airway better. So essentially, it does lead to an immunocompromising type of situation in which you have things in places where they shouldn't be. So is smoking weed as bad for you as smoking cigarettes? Well, I think the answer is it depends. If you're smoking 20 blunts a day, right, it's probably as bad as smoking 20 cigarettes a day. But in my experience, the experience of the friends that I know, they're not smoking 20 blunts a day. They might be taking a few hits of weed from their bong or whatever they're taking. So do I think that transiently it affects them? Yes. Do I think that, taking 2 hits of marijuana versus 20 cigarettes, do I think that the cigarette damage would be worse? Well, yeah, but it doesn't mean that the marijuana damage isn't present. It's still there. And that's why I still tell all of my patients not to smoke anything. But I do take that into account.
All right, I have a question here. As a videographer who's interested in going into medical school and becoming a doctor, do you think that I can combine my videography work with medicine to tell a story?
That's what we're doing. So I do. I think that story is important, which is why I'm here. So I feel that. So yeah, I think that you could, because you have a skill of telling a story, shooting a story, and being able to articulate the story in a medical way once you go through school is a combination that's fantastic. As a matter of fact, when you're done with medical school, give me a call.
Yeah, exactly.
Jimmy Productions.
Yeah, Jimmy Productions. Give us a call. All right. Let me see. This might lead into some stuff you wanted to talk about, this medical practices in general. Zoom and Gloom says, do you think doctors or nurses, RNs, have the best debt to income ratios?
No. That's an easy question. Do I think that doctors or nurses have the best debt to income ratio?
Doctors or nurses.
Doctors or nurses have the best. So I think for me, again, I'll tell you, like medical school for me was like 64 grand a year, right? And when I finished medical school, it ended up being 300 and some change owing, right? So I owe 300 and some change. My income, my first 6 years out of medical school was like 40 grand a year. So no, my debt to income ratio was crap. Nurses, I don't know, kind of depends. Like nursing schools in college, so you can get a nursing degree for, much cheaper than you can get a medical degree. So I think that their debt to income ratio might be a little bit better. But again, nowadays you have nurses getting their RN, getting their MSN, getting their PhD, getting their DNP, doing fantastic things. So I think that throughout all of those trainings, that's going to increase their cost of school as well. So their debt to income ratio could be just as bad as ours. But yeah, debt to income ratio is a thing.
Yeah. Yeah, good.
What's your opinion of the new nursing bill that was recently passed in California, the AB 890?
What's AB 890?
It's essentially giving a nurse practitioner independent practice rights.
All right. So he asked, what is your opinion of the nursing bill in California, which passed, which allows nurse practitioners to have independent practice rights? So here's how I feel about that. I feel that if a nurse has gone through the appropriate training and is comfortable in independent practice to practice medicine, then practice medicine. I think that in my experience, with the nurse practitioners that I've met, the ones that feel uncomfortable, that are uncomfortable, they're gonna let you know. And they will ask for supervision when they need it. I feel like people are adults and people can ask for supervision. Allowing a nurse to practice independently, for me, similar to allowing a physician to practice independently, because again, you can have bad physicians that may not understand how to do certain things, right? You can have bad nurse practitioners that may not understand how to do certain things. That's hard. It can be hard to tease out, right? Hopefully, with the initiation of these mock programs and understanding that we have to keep up with our boards and our education, you eliminate some of that from happening. But in my experience, having a nurse practice independently, especially in the areas in which healthcare is really needed, I got no problem with that, right? It's not like I'm going to go to that area and practice. I live here, right? Now, again, if you have the supervision, I think people welcome that. I mean, I still welcome that, and I'm year 6 into practicing on my own. I still call my old attending. I still call my old colleagues. And I'm like, hey, what do you think? What do you think? As long as people are willing to ask for help when they need it, I don't see an issue with that. Do I think that there are certain things that people practicing independently need to be taught? Like when to be worried and when they're in trouble and warning signs? Absolutely. Absolutely. There's no doubt about that. So if there's anything that I could think of, it would be, how do we assess that? How do we assess the ability to practice independently? But again, that goes with any field and anything.
When do you think the COVID-19 pandemic will end?
Not anytime soon.
Let them know.
Yeah.
I don't know if they can hear me really.
So the question was, when do you think the COVID-19 pandemic will end? Not anytime soon. I think we're about 1.5 years away from it being gone, right? And I think the reason I answer the question in that way is because we're clearly going to need a vaccine. The vaccine is what's going to eliminate this. It's not going to be anything else we're doing, because every single treatment that we're coming up with ain't the sauce. Ain't the sauce. There's one FDA-approved treatment, remdesivir. It ain't the sauce. It's not hot sauce. It's not doing anything. It's not enhancing anything. It might, maybe give you another day or get you out of the hospital a day sooner, but it has no impact on mortality. How it got FDA approved, I don't know, but it did. So that's what we give. Now, again, an argument can be made, oh, you didn't give it early enough. I'll accept that with every other argument too.
All right, here's a good one. Do you think restricting work hours for surgical residents will have a dramatic effect on the quality of their training? As in, do you think they will be worse surgeons by the end of residency? Go ahead and repeat it just in case.
So the question was, do you think that restricting hours on surgical residents, or any residents by that matter, is going to have an effect on their performance in surgery? Okay. Do I think the residents will be worse if they don't have the training? Here's the thing, and I've always thought this way. People who are the best and people who are great know how to be great. They're going to be great. They're going to be great. They're going to go out of their way. They're going to do things that maybe someone else isn't going to do. They're going to do the unnecessary things to enhance their skill, and they're going to be great. There's no doubt about that, right? The top 5 are the top 5. Period. End of story. That's it. The way that we overcome some of that is by repetition. 10,000 hours. Everybody's heard that, right? Spend 10,000 hours, become an expert, blah, 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 blah. When you take away work hours and you have work hour restrictions, that's just less hours. So as long as the program, whatever program that they're enrolled in, is efficient and can make certain that they get the cases that they need to perform well, I don't think there's going to be an issue with that. But I'm also a little old school. I went to med school from 2005 to 2009 and residency 2009 to 12, fellowship 12 to 15. The way that I was trained, we didn't really have any hours. The hours thing came out, I think, my second or third year of residency, when we were restricted to 80 hours a week. Now, I had no problem with that. I understood that. I got that I had to sleep there. I got that I had to be there all the time. I understood that. I studied all the time. I did all that. I recognize that not everybody was happy with that. And I recognize that all of the hours spent there maybe weren't completely necessary. However, I will also tell you that I got better the more time I spent there. That doesn't go away. It doesn't go away with anything. It doesn't go away. You don't get better by spending less time at something. What we have to find is we have to find a way to be efficient. I'm not a surgeon. I can't judge their skills. I can't judge their programs. I can look at education, and I am fully aware and I fully understand that the more time you spend in a hospital seeing patients, the more likely you're going to see this rare condition or that rare condition or this complication and that complication or this association. Sometimes things aren't complications. They just happen, right? When you biopsy the lung and you're sticking a hole in the lung to biopsy it, you're going to put a hole in it. If you don't put a hole in it and all the time that you spent there, then you don't know how to take care of that hole. That becomes an issue. You may not see a certain outcome. You may not see a certain association or complication. And that's the worry.
Right, because you don't get to watch the patient go through the whole process. And
right.
Also, I'm wondering, a lot of the great trauma advancements came out of Vietnam War and stuff like that. And these are doctors working under high stress circumstances with very little support.
Right.
Wouldn't you say that for surgeons, perhaps learning the physical resilience to be up for 48 hours straight and still think straight, is that something? Obviously you don't want to put people at risk, but there is a level of having to get tough.
There is a level of acceptance and absorbing things. Again, for me, you might be in the hospital for 24 hours and a case might come in. There's no other doctor there and it's 2 hours before your shift is up. And a case might come in that requires you to perform emergency surgery or some kind of an emergency, and you're going to be there more than 24 hours. So are you supposed to wait 2 hours for somebody to get there? You can't do that. You have to go and perform. So I do think there is a level of hardening, a level of acceptance, a level of getting through it. But I don't think it needs to be malignant. I don't need my program to, when I say I'm tired and I need a little bit of a break, I don't need them to say you're weak, you're soft, right? I think I need them to listen because everybody is different. I could take it. I could stay up for 3 or 4 days. I could do all that. Some people just can't, and that's okay. So we have to recognize that. Now, I do think as a medical student, as a college student, as a person, you have to get to know yourself. And you have to look at all the fields within medicine and say, is this something that I could do? Is that something that I could do? Because having the awareness of who you are and what you can achieve and accomplish is extremely important. So you got to spend some time getting to know yourself before you kind of just jump into a random field. That's what I would say.
Okay. Is there something that's super important for assessing a patient as far as respiratory goes? I have trouble discerning different breath sounds.
Yeah. So breath sounds are important, right? So being able to decipher between hearing crackles and hearing rhonchi. Yes. In the acute situation, does it matter? Maybe, not necessarily. If you don't hear breath sounds and you got an acute respiratory issue, maybe it's a pneumothorax. Maybe it's a collapsed lung. Maybe it's a lot of fluid. Being able to use the ultrasound, being able to read a chest x-ray and a chest CT in an acute situation is extremely important. It's invaluable. So there isn't any specific trick that I can give you that just says, yeah, if you know this, you're all good.
Okay. Let's see. Let me do somewhat of a broad question, but how do you think one ought to rectify the difference between the shortage of physicians in a given geographical location and the number of available residency spots?
How should we address the shortage of physicians versus the number of available residency spots? That's an interesting question because you need physicians to train the residents. So if there's a shortage of physicians, you can't just put residents there, right? Because that physician is going to be overworked in many different ways. He's got to not only, or she's got to not only teach the residents, but she also has to run the practice, right? And make sure that the patients are getting through okay. That's a very difficult question. I think maybe an answer to the question is allocating senior residents to certain areas of a region, if it's close to you, to get a lay of the land of the region, lay of the land of the hospital, and to help physicians in those areas that are deprived. Allow senior residents to perform a certain function, right? Again, general surgery residency is 5 or 6 years. Do I think that they could admit patients to the hospital after 2 or 3 years, just like I could when I was an internal medicine resident? Yeah, I do. I think that they could. Can they help with that? Yes. Should they be compensated for that? Yes, they should. So I think that finding a happy medium in there is important.
Nice. Okay. Let's see. Well, you've already kind of addressed your thoughts on the COVID-19 vaccine, worries about it being on the market too quickly. Let's see. I just finished undergrad in May and entered a special master's program this summer to help me prepare for medical school. It's a big adjustment. Do you have any study tips?
Yeah, I've got a YouTube video on study tips on this channel, on Medicine Deconstructed. But my study tips are this: make a schedule. Go out, have a good time, put that in your schedule. I did. But make a schedule and allow yourself to study. If you're just starting out and you're having difficulty, 60 minutes a day, start with that. Then the next week, do 90 minutes. The next week, do 120 minutes. The next week, 150, 180 minutes. Be able to sit down for 3 hours to 4 hours at a time and absorb information. You have to put it in a schedule, even on the weekend days, maybe even before you go out, whatever you want to do. You have to be on a schedule. That's like the first tip that I can give you. Second, when you're reading a book, especially a science book, there's a bunch of words that you read in a row. And when I was younger, even first year of medical school, there's a word that I didn't understand and I would just keep going. But you have to understand that to build that house, to build that foundation that you're trying to build, you can't skip a word. It's almost like skipping a column. And when you're building a house, if I don't put this column here, the ceiling is going to fall. Maybe it's not going to fall yet. Not going to fall until I add more weight to it. So until I put more information on top of the word that I don't understand, it's all going to fall down. You're not going to get it. So do not skip a word unless you understand it. You need to understand what you're reading, right? It's going to take longer. You're going to have to go back. I did. I had to go back all the way back, start over from scratch when I was a second-year med student. I had to read all of the normal shit again because I didn't pay attention enough. I skipped too many words. I got through it and I did well. I did just fine. But I didn't understand it as well as I should have. So you have to go back, and it takes some time, and then you start building. And then all of a sudden, people are going to start talking to you, and you're going to be able to connect this. You're going to be able to connect that. You're going to be able to build this house. And because of your schedule, and because you made a decision to not skip a word and to understand every word in that sentence, you got better. And you're going to notice it one day, and it's going to motivate you to become even better. And getting better and better every day is the goal. You want to be better today when compared to yesterday. Because in all honesty, it's not about being great on Friday afternoon at 3 o'clock. It's about being better on Friday than I was on Thursday. And that will lead to you being great. And you won't even realize it.
Nice. Well, I have 2 questions. I'm going to make them our last questions. A really heavy one and a really light one. So you pick which one you want first.
Heavy.
Okay. How often do you deal with terminally ill patients as an ICU doctor? I mean, every day, right?
Right.
How do you approach end-of-life decisions and discussions with patients' family members? It's a good question.
So how do I approach end-of-life decisions, right? And how many terminally ill patients do I have to deal with? Every day, I got to deal with a terminally ill patient. The way that I approach life in general, this is a stage. It's going to end. The two most, well, let me take that back. The most natural thing that we do is die. We die. We don't get to determine our time. We don't control when whatever higher power is taking us to the next stage of life. We don't get to control that. We have to develop the ability to communicate what is happening in a patient's body to a family member in such a way that they not only understand what it is their loved one is going through physiologically, but they also understand that there are things that we can do something about and things that we can't do anything about. And they understand it so well that when those things come up that they can't do anything about, they understand it's time to transition from this stage of life to the next. It's time to transition from a therapeutic scenario to a comfort scenario. It sucks. It's a hard discussion to have, but it's a necessary discussion you have to have. I had to tell that to a 7-year-old whose father died suddenly in the middle of the night. I had to tell that to a 60-year-old who lost their husband. These are the conversations you have to have. They're the most difficult conversations on the planet to have. But the reason that you can have them is because no one, not anyone on this planet, escapes the natural process of dying. We all go through it. It's just a matter of when we're going to go through it.
And then the light question, what is your favorite sneaker you own?
I get this question a lot. My favorite sneaker right now is actually right behind me. So these are bespoke Travis Scott, kind of like alligator suede Jordan 1s that the shoe surgeon made me. And you can see the backward swoosh, the cactus jack, the swoosh, the black and white silhouette, which I love because I can wear these with a suit. But right now, these are my favorite shoes. The Jordan 1 is a very versatile shoe because you can wear it with a suit. So that's my favorite shoe right now. I got lots of other shoes. You can see it in the Kicks episode that's there. And then I have lots of other shoes that I'm sure you'll see throughout all the other episodes. Thanks for being here, you guys. Appreciate you being here on Medicine Deconstructed Live. We're going to end this now. Subscribe, hit the notification button. But I got to get back to teaching Brian and filming the rest of these YouTubes. Good night.